Welcome to another CCRN review video. I'm Brent, and we'll get started. The cardiology portion on the exam is quite hefty in the content to go over. This is a very broad topic on the CCRN exam, so make sure you study this tremendously. So for example, here are the testable categories, and I'll let you read them for yourself. You can pause the video if you need more time. Okay, starting with the heart sounds. There are two normal heart sounds and two abnormal heart sounds. We'll start with the normal heart sounds first. The S1, the lub heart sound, is created by the closure of the mitral valve and the tricuspid valve. These are your AV valves, and when they close, they mark the end of diastole and the beginning of systole. These are heard loudest at the apex of the heart, and that is at the midclavicular line, fifth intercostal space on the left side. The S2 heart sound is the dub. This sound is caused by the closure of the aortic and pulmonic valves, and these are your semilunar valves. The closure of these valves mark the end of systole and the beginning of diastole. The S2 heart sound is heard loudest at the base, which is the right sternal border, second intercostal space. These often can be elevated in sound with pulmonary embolisms. Here's an example of the heart sound auscultation points. These are not the S1, S2 points. These are each individual valve. For the abnormal heart sounds, we'll start with S3. This occurs early in diastole, right after the S2 sound. It can be heard best in the apex of the heart with the bell of the stethoscope. These are abnormal in adults, and think the way it sounds like Kentucky. Kentucky. This S3 sound is caused by a rapid rush of blood into a dilated ventricle, which can present in pulmonary hypertension or cor pulmonale. Also can be caused by inefficiency of the mitral valve, aortic valve, or the tricuspid valve. The S4 sound occurs right before the S1 heart sound. It can be heard best at the apex of the heart with the bell of the stethoscope. This abnormal sound sounds like Tennessee. Tennessee. This is associated with aortic stenosis, ventricular hypertrophy, and hypertension and myocardial ischemia. There's also pericardial friction rubs, which can be primarily due to pericarditis and can be associated with pain on deep inspiration, and it could be positional. For the test, if you have a question that says that they have pericardial friction rub, then you need to rule out pericarditis. Some of the abnormal heart sounds can be murmurs, which is often caused by valvular heart disease. Some of the common causes of valvular heart disease include infections, dilated cardiomyopathy, coronary artery disease, acute MI or ischemia, bicuspid aortic valve, which is abnormal. Remember, it's a tricuspid. Rheumatic fever with rheumatic heart disease, and connective tissue disease. So on to murmurs. This is caused by two different types of physical attributes. You have murmurs of stenosis, and you have murmurs of insufficiency. This is also called regurgitation. Murmurs of stenosis occur when the valve is open and can develop over time. This is a chronic problem and it's not acute. Murmurs of insufficiency, however, occur when the valve is closed, and it can be acute or chronic. Big one to remember for this one is the mitral valve. It can be acute as far as papillary muscle rupture. That is a surgical emergency. We'll go over that further in the video. So systolic murmurs. This is the murmur in between the S1 and S2 sound. So it'll sound like lub, sh, dub. Lub, sh, dub. So it only occurs during systole when the two valves are closed and two valves are open. The valves that are open are the aortic and pulmonic valves. These are murmurs of stenosis. So you can have a stenosis murmur with a systolic murmur. So the aortic stenosis and pulmonic stenosis sound really rough and gruff sounding. The mitral and tricuspid valves are closed during systole, and these are murmurs of insufficiency. With systolic murmurs and diastolic murmurs, you can have both a systolic stenosis murmur, you can have stenosis or insufficiency murmurs on systolic murmurs, or you can have stenosis and insufficiency murmurs on the diastolic murmurs. So just be aware of that. Mitral insufficiency and tricuspid insufficiency, they sound like hard blowing sound that radiates significantly throughout the chest. The mitral can cause a large V-wave pattern on the pulmonary artery occlusion pressure tracing. The systolic murmur can also be from a ventricular septal defect, which can be congenital, or it can occur in acute MI. So be aware of that. The diastolic murmur is the murmur after the S2 sound. So it sounds like lub-dub-sh, lub-dub-sh. This only occurs during diastole while 2 valves are open and again 2 valves are closed. So that's the reason why you can have a murmur of stenosis and a murmur of insufficiency in your diastolic and systolic murmurs. The mitral stenosis and tricuspid stenosis sound like a rumbling sound. Mitral stenosis can be due to atrial enlargement and subsequent atrial fibrillation. And this is here due to the location of those valves. The aortic and pulmonic valves are closed during diastole, and these are murmurs of insufficiency, again, which is also called regurgitation. Aortic and pulmonic insufficiency sound like a blowing sound. Some murmurs can happen acutely, they can happen chronically, and you need to determine on the test if this is acute and if you need to treat it. So murmurs in acute MI include myocardial ischemia or infarction and can affect the mitral valve function and lead to acute mitral valve insufficiency. Due to the location of the mitral valve, which is attached to the left ventricular wall by papillary muscles and the chordae tendineae. Papillary muscle dysfunction and rupture can occur, which will cause dysfunction or muscle rupture. The papillary muscle rupture is, again, like I mentioned before, is a surgical emergency. These are both heard loudest at the apex. Moving on. So let's take a little bit of murmur review. Remember what the aortic valve is doing, the pulmonary valve is also doing. Remember what the mitral valve is doing, and the tricuspid valve will follow as well, and vice versa. Aortic insufficiency occurs when the aortic valve is closed. When is the aortic valve closed? Remember that is diastole. Mitral insufficiency occurs when the mitral valve is closed. When is the mitral valve closed? Systole. So you can see that insufficiency murmurs occur both with diastole and both with systole. And the same goes for stenosis. Moving on to blood pressure and pulse pressure. Your pulse pressure is the difference between the systolic pressure and the diastolic pressure. So systolic pressure minus your diastolic pressure is your pulse pressure. The normal pulse pressure is 40 to 60 millimeters of mercury. 120 minus 80 is 40, so that's a normal pulse pressure, although on the lowest side. Systolic BP is an indirect measurement of the cardiac output and stroke volume, and diastolic BP is an indirect measurement of the systemic vascular resistance. These are 3 numbers that you need to be aware of and how they function and how they work. In this video, I'm not going to go into that, but I will upload further videos to explain SVR and stroke volume and cardiac output and other hemodynamic values. For the test, know that coronary arteries are perfused during diastole. This works well because diastole is typically 1/3 longer than systole. Just be aware of that. So for the test, you'll probably have one question on hypertensive crisis or urgency emergency. Just know that hypertensive emergency is an acute elevation of blood pressure that shows evidence of end organ damage. So this actually has to have an acute blood pressure elevation and shows evidence of organ damage. So we're talking about brain, heart, kidney, retinas of your eyes. We're talking about retinal hemorrhaging, elevation of a kidney, creatinine, BUN, heart murmurs, brain confusion, signs of increased intracranial pressure. So they have to have both of those. And if you get the patient with hypertensive emergency, you're going to admit those to a critical care unit. For the hypertensive urgency, this is an acute elevation of blood pressure without evidence of end organ damage. So you're going to watch this patient, you could admit them to the critical care unit, but it's probably more appropriate to manage their blood pressure before there is end organ damage. So goals in both the urgency and the emergency is to lower the blood pressure. That's pretty simple. To do that, you can use a drip or intermittent blood pressure medications. The continuous drip of choice on the CCRN exam is the nitroprusside. This reduces the preload and afterload, but people that are on this drip for a few hours to a few days, you need to assess for cyanide toxicity. One of the first signs of cyanide toxicity is mental status change, tachycardia, seizures, and metabolic acidosis. And this is due to renal impairment. Often the more safe drug to use, and it's intermittent, labetalol. You can give up to a max dose per day of 300 milligrams total, and it lasts a fair amount of time, between 4 and 6 hours. So you control the blood pressure over time, however it's much safer for the patient. One of the worst outcomes as far as the hypertension urgency or emergency is concerned for the CCRN test is stroke. There's also other risks, including retinal hemorrhage and papilledema, which I mentioned on the previous slide. And papilledema is optical disc swelling. Often your optic disc swells because of increased intracranial pressure. Okay, so for your other notes, there may be, again, a question about this on the test. Accelerated hypertension, your diastolic is 120 millimeters of mercury or greater. And notice malignant hypertension is the diastolic is greater than 140. And as Laura Gasparis says, not 140, greater than 140. And just a note, they just changed the blood pressure guidelines. I don't believe they mentioned malignant or accelerated hypertension, so that should still be the same for the CCRN test. As we know, certification tests take 2 or 3 years to update to current research. So that's it for the blood pressures. Moving on to acute peripheral vascular insufficiency. So this is the disease where your vascular system is insufficient. You can have insufficiency both on the arterial side and the venous side. So let's go over the arterial side. Signs and symptoms of acute or chronic peripheral artery disease is pain, pallor, pulse diminished or absent. And these are going to be your distal pulses or your peripheral pulses, paresthesia, paralysis, and poikilothermia. The poikilothermia is the chronic signs, which is loss of hair on lower extremities. This is due to loss of or decreased circulation. Glossy, thin, cool, dry skin, which will also be cool to touch. These can almost look transparent, thin looking. You'll know it when you see it. Some of the diagnostic tests in peripheral vascular insufficiency include Doppler ultrasound or arteriography. The ultrasound will just measure for flow or blockage. The arteriography is used with contrast, and you can measure how much flow does get through and what vessels it gets into. I believe there's one question on the ankle brachial index. Just know for the test that normal is greater than 1. And to get this, you're going to divide the ankle pressure by the brachial pressure and make sure you're doing that on the same side. So if it's on the right leg, you need to do the right arm. Once you divide those numbers, if it's greater than 1, you're good to go. If it's not greater than 1, then you've got some flow insufficiency. For the artery side of insufficiency, you're not going to elevate this extremity. That's going to decrease the perfusion to an extremity that's already working its way to being ischemic. For the test, you can increase your circulation, or at least not reduce it, by placing the bed in reverse Trendelenburg. Not extremely high, but just enough that its gravity is going to help. Medications that can help with peripheral artery disease include vasodilators, antiplatelet agents such as aspirin and clopidogrel, also known as Plavix, and thrombolytics such as TPA. Of course, TPA is not going to be used chronically. That's just something to be aware of for the test. Some patient care management as well. It can be an embolectomy. You can do a bypass graft and angioplasty for your vessels. Just know that. Moving on to aneurysms. An aneurysm is a blood-filled outpouching of the wall in an artery. The larger the aneurysm, the more likely it may rupture. So for the test, I don't believe you're going to know the sizes of the aneurysms, but just know that anything less than 3 or 4 centimeters is something that's going to be okay to watch. And something that's greater than 4, 5, or 6 centimeters is going to be a surgical consult, just depending on where the location is and how fast it's growing, and if there's signs or symptoms that go along with that. Risks that contribute to aneurysm, just know that hypertension, smoking, obesity, arteriosclerosis, bacterial infections. It could be congenital. Your family history of aneurysms, we often check that in primary care, just part of your physical exam if there's a history of aneurysms. Trauma, and Marfan syndrome. This is one of the connective tissue diseases. People with Marfan syndrome, this is a connective tissue disease that I mentioned earlier. One of them, and that could be on the test. But people of these syndrome are typically taller, more skinny, lanky looking, often have aneurysms, other connective tissue disorders. These people are more likely to have a risk of rupture. So the types of aneurysm that can be on the test certainly can be brain aneurysms, or any aneurysm that is an artery. But for the test, we're going to learn about the brain, but this particular slide right here is going to be the abdominal aortic, and then we'll go on to the thoracic aortic. So treatment for small aneurysms that are asymptomatic, you're just going to watch. But it could include pulsations in the abdomen. But if you start having symptoms, those symptoms are going to be low back pain, abdominal pain, nausea, vomiting symptoms, and shock. And when I say symptoms, I mean when the aneurysm is growing or expanding and getting bigger, you risk for dissection or rupture. Those are the symptoms these patients are going to be having. And it's going to be acute as far as the signs and symptoms go. So the thoracic aortic aneurysm presentation typically are going to be a lot more rare than the abdominal aortic aneurysms. The abdominal aortic aneurysms are roughly 75% of people. Thoracic aortic aneurysms are about 25% of patient presentation. Some of the signs include the widening of the mediastinum on chest x-ray. So that's one of the classic signs. If you hear that in an exam or a test question without actually seeing the chest x-ray, you know that this is possibly a thoracic aortic aneurysm question. Also signs of dysphagia, dyspnea, dizziness, difficulty walking, sudden tearing or ripping pain in the chest, which can radiate to the neck, shoulders, and back. Also cough and hoarseness. This is all because these signs are due to just the sheer location of the anatomy. The aneurysm portion, this is the treatment. So less than 5 centimeters and no symptoms, you're just going to monitor maybe once a year. Every couple of years, you're going to do an ultrasound or CT scan. Hypertension, you're going to want to use beta blockers are very important for the cardiovascular system. So use beta blockers if you can tolerate. Marfan syndrome, again, you may need treatment sooner because these people are more predisposed to ruptured aneurysms just based on their connective tissue disease. Greater than 6 centimeters for the test. With acute symptoms, you're going to go for basically aggressive or urgent surgery. If they're not having symptoms, you can certainly schedule a surgical repair, but for the test, everything's going to be mostly acute. So you're going to go in for a surgical repair. And you definitely want to get that blood pressure down and heart rate down. Often these patients can be on a labetalol drip. For the aortic dissection, this is definitely life-threatening. There's 2 types, type A and type B. But for the test, just know the aortic dissection generally, the concept of the aortic dissection. Don't believe they get too specific on the test. The tear is spiral and can be sudden or gradual, most common in ascending aortic or aortic arch, so that's type A actually, and this requires immediate surgical intervention. A lot of times these patients can have calcified aortic arches, really hard, brittle aortic arches, so it's definitely a dangerous and serious surgery. Moving to cardiac trauma. There's a few questions on cardiac trauma. So just know that myocardial contusion is cardiac trauma, and you can have pericarditis from both a medical or trauma reason, so that's why it's listed under cardiac trauma. Know for the test that pericardial contusion has a worse outcome than pericarditis. So if the contusion, this is damaged blood vessels that bleed into the heart, kind of like a bruise, similar to signs and symptoms of an MI. This is again based on the anatomy. So you're going to have chest pain, dyspnea, low-grade temperature, ST elevation, and the area of injury. And we're going to go over the ST elevation and the leads and what views they look at later on in the video. So this has a worse outcome than pericarditis. Again, you can have cardiac dysrhythmias as well. Death can occur within the first 48 hours. So for the myocardial contusion patients, you're going to need to monitor for arrhythmias and pain medications. And due to the anatomy, because your aortic valve is most anterior in the chest, the most front side of your chest, it's the most risk for the trauma. So in pericarditis, this can be, again, caused from trauma or surgery, and can be viral or idiopathic, and as well as bacterial in nature. Some signs and symptoms are similar, but some are different. So we have chest pain, worse with inspiration. This is due to basically your lung lining and your parenchyma of the lung irritating your pericardial sac. Also dyspnea, low-grade temperature, increased sedimentation rate due to the inflammation, and ST elevation in all leads. This is the one that will set it apart from the myocardial contusion questions. So ST elevation in all leads, you're more than likely looking at pericarditis. Also, this can cause cardiac tamponade. Treatment is slightly different. You're going to give pain medications and anti-inflammatory medications such as NSAIDs, steroids, antibiotics. Pain medications can certainly help patients twofold. It can help with anxiety from the pain, shortness of breath from the pain, that sort of thing, and antibiotics, of course. So you're going to monitor for constrictive pericarditis and cardiac tamponade. Moving on to cardiac tamponade. So this can be from trauma, pericarditis, post-op cardiac surgery. Some of the signs and symptoms include hypotension, increased jugular vein distension, restlessness, agitation, muffled or distant heart sounds, enlarging of the cardiac silhouettes, and mediastinum on the chest X-ray. So this is two things on the CCRN exam that could be, that mention X-ray. Thoracic aortic aneurysm or dissection, and you have your cardiac tamponade. Both of these are going to widen the mediastinum on the chest X-ray. Just know that the cardiac tamponade is going to come with some other things. It's going to come with more agitation and less pain. Pain that presents differently. You can also have equalization of the central venous pressures, your pulmonary artery diastolic pressures, and your pulmonary artery occlusion pressures. So be sure to look at the hemodynamic video for the normal and abnormal levels and what they mean. You can end up with pulseless paradox. So this is when you take a deep breath on inspiration, your blood pressure is going to drop. You don't really catch this unless you have an arterial line, and of which you do need to know on the test. And also you're going to have a narrowed pulse pressure due to the nature of the tamponade. So remember 40 to 60 is the narrowed pulse pressure. You're going to see that get down below 40. So you could see your blood pressure getting to 90 over 60, 90 over 70, that sort of thing, or 80 over 50, 80 over 60. Just be aware of that. So pulseless paradox, narrowed pulse pressure for your cardiac tamponade. Moving on. Getting into cardiac surgery, this is your coronary artery bypass grafting. To qualify for your CABG, you need to have 3 major vessel disease, or a left main vessel disease, or a left main disease which includes symptoms such as chronic angina, unresponsive to therapy, and not a candidate for a PCI intervention. So to qualify for a CABG, you have to have these, at least for the test, one of these qualifying factors. No for the procedure for the test. Often heparin is given in large, very large doses. They're going to want to put the patient in a state of hypothermia, and enhance oxygenation by hemodilution using isotonic fluids. And this is all to reduce the workload on the heart, to reduce the oxygen demand on the heart, and to increase your patient outcomes. So to stop the heart during this test and to be able to put on the bypass machine, they'll have to use potassium cardioplegic drugs, which is infused at intervals throughout the procedure. Just know for the test, the longer the bypass time, the longer the patient is in surgery, the higher the complication rates. And this is due to primarily more bleeding post-op, meaning gotten more and larger doses in heparin during surgery. So that's going to make it worse for the outcome. Post-op CABG, the nursing is going to assess for several things: arrhythmias, tamponade, pericarditis, again, hemodynamic abnormalities, electrolyte abnormalities, again, bleeding, pain and anxiety, other signs of infection. Post-op CABG patient is going to have chest tubes, so just know that you need to maintain patency, no dependent loops. Generally, for the test, no milking or stripping the chest tubes. If you see a larger clot that does block the chest tube for the test, then you can milk it with a gentle technique, but generally, no milking or stripping. You need to keep the drainage system lower than the chest. Obviously, do not clamp the drainage system. For the test, if the output is greater than 100 milliliters for 2 consecutive hours, these have to be 2 consecutive hours, you need to make the doctor aware, be prepared to give blood products, and maintain the volume status. You don't want the heart and the vessels to get ischemic. That obviously is going to do bad things for healing. Continuing on with cardiac surgery, you have your valve surgeries. And now there's 2 types, your biological valve and your mechanical valve. Your biological valve has some advantages and disadvantages. So your biological valve, you only need, for the most part, coagulation for the short term, which only may be aspirin. unfortunately, it wears down, and especially in the setting of hypertension. So these hypertensive patients may need to have a mechanical valve. The mechanical valve is easy to place during surgery, it's reliable, and it lasts longer than a biological valve. However, there's an increased risk of thrombosis, so that's why we're going to keep these patients on permanent anticoagulation therapy. Not just aspirin, they're going to need to add Plavix, and most patients are on Plavix and aspirin. Just know post-op, you can certainly have conduction abnormalities. The tricuspid, the mitral, and the aortic valves are really close to the conduction pathway. So if you replace one of those three valves, or all three, certainly have some arrhythmias or bradycardia. So in these patients, post-op, you're going to want to avoid reducing the preload. This is because when you have a patient with chronic valve disease, that can essentially elevate the end diastolic volumes, so the heart gets used to that, the system gets used to that. So when you drop the preload, you're going to have a really severe hypotensive patient. Don't want to do that. So avoid dropping the preload in valves surgery. In this video, we're not going to go over arrhythmias, and I don't believe there is many strips on the test. If there is a strip, it's going to be pretty general. But just understand arrhythmia interpretation and understand the ACLS protocols. Just think, is this patient stable or unstable if they have an arrhythmia? If somebody's in SVT and they don't have a drop in blood pressure, they don't have shortness of breath, they don't have confusion, then you're not going to go cardioverse the patient immediately. You're going to just consult cardiology. So if you do get an interpretation or arrhythmia example on the test, just look for signs of them being stable or unstable, and what would you do? So know that if there's not a description for the question, to rule one of those two things out, do not write a story and don't assume the patient response. Only go by with what the question presents. So one of the things that can lead to arrhythmias is prolongation of the QT interval. Just know the causes and know the treatment. So, causes can be drugs, can be electrolytes. There's Sotalol also does it, amiodarone. You just want to be aware of those in the treatment. So obviously treatment for the drugs would be changing the drugs, but for the treatment for electrolyte disturbances, there's only one big one for the test, and it's if the patient goes into torsades, you're going to want to give them magnesium. Of course, replace the electrolytes. Normally, hypokalemia, you're going to give them potassium, that sort of thing. Pacemakers. This is actually pretty easy on the test. You just need to understand the basic initials with pacemakers. You can have three placeholders for these initials. And so for the first initial, this is going to be the chamber that is paced. The reason it's the first initial is because the pacing mechanism was invented first, before you could sense. So that's the reason why it's first. So the first initial is the chamber is paced. The second initial is the chamber that is sensed. This was invented second. So hence the second initial. The third initial is the pacemaker's response to the sensing. Remember that no response is still a response. You can have one of three letters in the third initial spot. You can have I for inhibits. Once the pacemaker senses the cardiac activity, then I is going to inhibit itself, meaning it's only going to pace when it's needed as far as demand goes. So if there's any cardiac activity and it's higher or at the same rate as what the pacer would do, then it's going to inhibit itself from pacing. But again, if it's lower based on the sensing, then it's going to go ahead and be demanded, so then it's going to pace. So the second placeholder for the third initial is D. This means dual, essentially. It's going to inhibit and trigger. So the sensing area, when you detect the cardiac activity, it is going to, number one, inhibit itself from firing on the T wave or within the R wave. And then it's going to send a pacing response, a trigger. So it's going to inhibit itself and long enough to fire the pacing response in the appropriate location. So it's both. And this is every heartbeat. With the I, with it just inhibits, it's going to mainly inhibit itself from doing anything and only paces once or twice or not at all. So just remember that. A little bit confusing. Hopefully I've explained it a-okay. And then O is for none. So that means it's not going to sense or inhibit, and it's not going to send a pacing signal based on that sensing. So A means atria, V means ventricle, and D means dual. This is going to be the chamber that is paced. So we'll go over an example here next. So for example, how does a DDD pacemaker work? Well, you got to think, what's the first initial? It is the chamber that is paced. All right, so since it's D in the first initial spot, this is going to be both chambers for dual. So the atria and the ventricle is going to be paced. The second initial, D, again, you're thinking dual. All right, so this is the chamber that is sensed because it was invented second. So in this case, both chambers are sensed, the atrium and the ventricle. The third initial, D, is the third initial spot. This is going to be the pacemaker response to the sensing. So remember, we can inhibit the response, we can inhibit and then trigger for the second response, or we can do nothing at all. So in this particular case, the third initial is D. This is going to stand for not dual, or it can be dual, but for the third initial spot, this means it's going to inhibit and trigger. So what about the VVI pacemaker? I want you to do that one on your own. Pause the video if you need more time. We'll go over it in about 5 seconds. So the VVI pacemaker, think again, is going to be the ventricles that are paced. Secondly, the ventricles that are sensed. The third initial is the I, which is the pacer's response to the sensing of the ventricle. So we're going to inhibit a response. This means it's only going to fire on demand. Heart failure is a very, very, very broad topic for the CCRN exam. There's a bunch of both systolic, diastolic, right-sided versus left-sided. So just know you've got to know the general signs and symptoms, the mechanisms of action, and your treatments for the heart failure and the heart failure classes. So for heart failure, you're going to have acute, a chronic, or an acute exacerbation of a chronic heart failure. So you need to understand right-sided versus left-sided, and if it's systolic versus diastolic heart failure. Just know the general concept. Heart failure patients generally have high intracardiac pressures and decreased cardiac output. For the exam, you need to know what the BNP lab level is, which is the brain natriuretic peptide, released by the ventricles when the ventricular wall is under stress and attempts to dilate due to trying to decrease the intraventricular pressure. So those pressures are high because of heart failure, and the ventricles are going to try to compensate for that by releasing this BNP protein. In heart failure, the BNP level's high and is a direct indicator of when the left or right ventricle is under stress. Notice I did not say atrium, so it's released from the ventricles. For systolic heart failure, the qualifier for the CCRN exam is an ejection fraction, an EF, of the left ventricle of 40% or less. This is an indication of a problem with ejection. So systolic heart failure, an ejection problem. For the diastolic heart failure, ejection fraction can be normal, can be slightly decreased, but it wouldn't be under 40% typically. You're going to have a problem with filling. So the blood that enters the heart, the blood that does get in the heart, a normal amount gets out with each stroke of the heart. The heart failure classes for the test is here. You can look at those. I'll briefly go over them. So class 1 is no heart failure symptoms, chest pain, shortness of breath, that sort of thing with ordinary activity or exercise. Only extraordinary activity results in heart failure symptoms. So not even jogging would cause these patient symptoms. It's, running a mile as fast as they physically possibly can. That would exhibit some heart failure symptoms. Class 2. People are comfortable at rest in this class. Physical activity results in a little bit of heart failure symptoms, which may limit some physical activity. These patients are not going to be going out and running that mile as hard as they physically possibly can. but generally people can live pretty comfortable in the class level 2 of heart failure. Class level 3 is being comfortable at rest, but just light activity results in heart failure symptoms. Again, that shortness of breath, chest pain, dyspnea, orthopnea, that sort of thing. This definitely has some increased limitation on physical activity. Class 4 is the worst class as far as the CCRN goes. These are symptoms of heart failure at rest. This is with any physical activity. This is going to increase their discomfort. Severe limitation on activity. These are the people that can get into the chair and they're worn the heck out. Systolic heart failure. We're going to go over acute systolic heart failure. This is sort of like a timeline of what's going on in decompensated systolic heart failure. So due to the increased heart pressures and heart failure, the ventricular wall is going to have an abnormality, meaning it's harder to beat. Could be due to cardiomyopathy, acute arrhythmias, valvular dysfunction, coronary artery disease. Once the wall motion abnormality is recognized, then the left ventricle is obviously unable to eject normally. Since the ventricles, especially the left ventricle, is unable to eject normally during this situation, again due to valvular dysfunction or arrhythmias, this leads to the EF of being less than 40%, which again is systolic heart failure. This increases the left ventricle end diastolic pressures, the LVEDP. So later in the video, I'll show you or tell you how you could measure the left ventricle end diastolic pressure. Just know for this section, an EF of less than 40 is abnormal. So we're going to move on to the third step, which is the development of pulmonary edema and hypoxemia. So when you have an end diastolic pressure in the left ventricle that is abnormal and high, then you're going to develop a backflow or a blockage, essentially, as far as pressure is concerned, into the pulmonary system, causing pulmonary edema, hypoxemia. Catecholamine is released to increase systemic vascular resistance. So what this is doing is going to essentially constrict the vascular bed, or your vasoconstrict, to attempt to compensate for the end diastolic pressure that's elevated. If the system continues, then you're going to have a systemic or an overall decrease in cardiac output, which leads to hypotension and further increase in SVR. So your body's way of being able to compensate for hypotension is to increase the SVR, your systemic vascular resistance. Unfortunately for the body, when you have an increase in systemic vascular resistance, you're also increasing the afterload on the heart. It's making it harder for the heart to pump. So this is why we give drugs that combat this system in heart failure. So again, some of the signs include pulmonary edema, shortness of breath, hypotension, and an S3 heart sound. Remember S3 heart sound? So continuing on, the medications for heart failure is to, again, help fight the system, the body's natural mechanisms of making heart failure worse in an attempt to make it better. So you're going to try and help reduce the ventricular remodeling and thus further worsening of heart failure again. You're going to use drugs to do this by using beta blockers. This prevents the effect of norepinephrine. And you're going to use angiotensin converting enzyme inhibitors. This is prevent the effects from angiotensin 1, which is eventually going to be converted into angiotensin 2. That's why we can give the ARB drugs, the angiotensin receptor blockers, and these prevent the effects from angiotensin 2. You can also give diuretics, and these help prevent the effects from sodium-water retention in heart failure. In the setting of hypotension, an example, heart failure, your body is going to try to compensate by doing two things. And those two things are the angiotensin system and the aldosterone system. For the aldosterone system, your kidneys are going to start retaining sodium and water in an attempt to increase your blood pressure. Unfortunately, for a heart failure system that already has increased SVR, increased systemic vascular resistance, left cardiomyopathy, a floppy heart, you do not need extra sodium and water. So that's why we give the diuretics to help combat this as well. So you also want to give positive inotropes. This will essentially help the heart beat, which will allow it to fill more and beat a little stronger. So contraindicated in systolic heart failure is negative inotropes and calcium channel blockers. Moving on to diastolic heart failure. Diastolic heart failure can be less complicated and less severe than systolic heart failure. Just know that this is due to the development of chronic hypertension, valve disease, and hypertrophic cardiomyopathy. So again, you're going to have these bigger hearts. You're going to have ventricles that aren't able to relax because of such the pressure on the system. So this leads to a left ventricle that becomes stiff from the inability to relax. Again, this is going to increase your left ventricular and diastolic pressures. Again, heart failure, you're going to have high intracardiac pressures and hypotension. So you're going to develop pulmonary edema. This is going to back up into the system. So signs and symptoms include fatigue, dyspnea, chest pain, palpitations, S3 or an S4. What's an S4 again? So also you're going to have syncope. And those are some of the things to look out for in diastolic heart failure. So again, some of the diastolic heart failure medications are going to be very similar to the systolic heart failure medications, your beta blockers, your ACE inhibitors, your ARBs. But in this one, you can give calcium channel blockers. However, you don't want to decrease the preload. The heart already has problems filling. So if you decrease the preload, you're going to slow the filling times down even worse. So low-dose diuretics and diastolic heart failure, that's really just going to maintain the sodium water retention. You're not supposed to really knock it out altogether because, again, you're going to decrease your preload, further worsening your filling times, which would make the patient a lot worse. So contraindicated positive inotropes. You don't want them dehydrated, again, because of the preload, and tachyarrhythmia, again, because of the filling times. Right-sided versus left-sided heart failure. So your right-sided heart failure causes are listed here: pulmonary embolism, acute right ventricular infarction, septal defect, pulmonary stenosis/insufficiency, COPD, pulmonary hypertension, and left ventricular failure. So some of the signs and symptoms of right-sided heart failure include dependent edema, venous distension, elevated central venous pressure, jugular venous distension, abdominal pain. And this is due to the fluid backed up and the pressure in the system. Ascites, that sort of thing. Hepatosplenomegaly and just splenomegaly. And tricuspid insufficiency. So you've got all this fluid and pressure backing up into the body system, the body circulatory system. Left-sided heart failure, some of the causes are fluid overload, which you can end up in with left-sided heart failure, so it's like a revolving door. Chronic hypertension, cardiac tamponade, cardiomyopathy, acute MI or even an old MI, aortic stenosis or insufficiency, mitral stenosis or insufficiency, and coronary artery disease. So left-sided heart failure causes a baggage up into the lungs, not necessarily the body. So signs and symptoms of left-sided heart failure include hypoxemia, tachycardia, crackles, cough, often with pink and frothy sputum, orthopnea, dyspnea, tachypnea, diaphoresis, anxiety, confusion, elevated pulmonary artery diastolic, and elevated pulmonary artery occlusion pressure. That's because you are ending up with patients with pulmonary hypertension from fluid overload, from these pathology they've gotten from left-sided heart failure. Cardiomyopathy, you're going to be looking for the test being dilated versus hypertrophic. Dilated cardiomyopathy is systolic dysfunction, and that's because when you have a dilated left ventricle, it enlarges, it thins out, it dilates, and then since the mitral valve is right over there, you're going to end up being insufficient because of the dilated left ventricle. It's not going to be able to close as well as it could have been. So remember, you're going to have problems ejecting when your left ventricle squeezes. That since that mitral valve isn't closed quite all the way, then you're going to have some regurgitation through that mitral valve, ending up with a problem ejecting through your pulmonary valve. So some of the signs and symptoms are very similar to systolic heart failure. And if you need to review those, go back to the portion of the video with systolic heart failure. Also, these patients may need a ventricular assist device or a heart transplant So you're going to have a patient on a VAD waiting on a heart transplant due to the thinning and the dilation of the enlargement of the left ventricle. So you think mitral valve insufficiency, why don't you just replace the mitral valve? It's not going to work that way. I suppose you could. However, the ventricle is still going to be floppy, it's still going to be dilated, and then you can end up with a new mitral valve that develops the same issue. So the fix for that is a heart transplant or a ventricular assistive device until you get compensated enough to go back home to come back, 3 months from now. Hypertrophic cardiomyopathy is the diastolic dysfunction. So remember, this is going to be problems filling. Hypertrophic is enlarged, so you think the septum of the heart is going to be enlarged, the ventricle, the wall is going to be enlarged, it's going to be thick. It's not going to be a lot of room in there to allow blood to fill in the heart. So these patients are going to have similar signs and symptoms and treatment to diastolic heart failure. Again, don't reduce the preload in these patients. You're going to need as much pressure to push blood into that hypertrophic ventricle as needed, as much time as you need. And then, since you're trying to correct the filling problem, then once it gets in there, it's going to be ejected just fine. These patients are at risk of sudden cardiac death. Just remember that. Hypertrophic cardiomyopathy patients are at risk of sudden cardiac death. In heart failure, you can have a presentation of cardiogenic shock. This is the worst presentation of heart failure. So you have your class 1, class 2, class 3, class 4. You get an acute exacerbation of class 4, you're going to end up in cardiogenic shock. This develops when compensatory mechanisms fail to maintain cardiac output, and this results in a drop in cardiac output that does not adequately perfuse the organs when your mean arterial pressure gets down too low. This, again, increases your left ventricular preload, and that's measured by your pulmonary artery occlusion pressure, and it results in increased left ventricular afterload, and this is measured by your systemic vascular resistance. This is due to vasoconstriction and other compensatory mechanisms. Some of the things that can cause cardiogenic shock, not only acute exacerbation of heart failure, but acute MI, cardiomyopathy, chronic heart failure, dysrhythmias, cardiac tamponade, and pulmonary muscle rupture. This is going to affect your mitral valve, so it's life-threatening. Remember, if it's dysfunctional, you need to get it repaired. If it's ruptured, that is life-threatening. So cardiogenic shock early, there's 2 stages, early and late. So this is when the body is trying to compensate, but not doing a great job. So you're going to have tachypnea, tachycardia, crackles, mild crackles with hypoxemia, anxiety, irritability, neck vein distension, not just your jugular, cool skin. Remember the cool skin, decrease in urine output. It's because the kidneys are being perfused less. You're going to have your narrow pulse pressure. Again, what's that normal? 40 to 60. You have a stable BP, however, it's going to be lower than baseline. Your heart's trying to do, your vascular system's trying to compensate. However, it's not doing the greatest of jobs, so your blood pressure is going to be lower. These patients will progress to the late stage if it's not corrected. So since you have tachypnea and anxiety, that sort of thing, you're going to be breathing a lot faster. And so the ABG is going to show respiratory alkalosis. But when you start to see the respiratory acidosis, that's when you're going to start to getting into the late stage of heart failure. So late stage, the progressive stage, you're going to see hypotension can be severe, life-threatening, worsening tachycardia, worsening tachypnea, further decreased urine output. You're going to be oliguric or less. You can even be anuric. Worsening crackles, worsening hypoxemia, you're going to have clammy, mottled skin, and worse anxiety that's going to progress to lethargy. This is because these patients are not only worn out, they've got a respiratory acidosis building up. This is not only due to them being exhausted from breathing, but you're going to have the respiratory acidosis. So they're going to have an increase in CO2 levels, which can make them lethargic in itself. So this can occur at any time chest pain or arrhythmias occur. So you can have a patient that's A-OK, and all of a sudden they have chest pain and arrhythmia, and then all of a sudden, an hour later they're in cardiogenic shock because that cardiac output is affected, stroke volume could be affected, that sort of thing. So you need to watch, you need to assess and maintain assessments for cardiogenic shock when you have a patient that has chest pain or arrhythmias. In cardiogenic shock treatment, first you identify the cause. If it's a STEMI, you're going to do a PCI or fibrinolytic therapy or both. If it's an arrhythmia, either bradyarrhythmia or tachyarrhythmia, you're going to treat the arrhythmia. If it's a papillary muscle rupture, again with a mitral valve, or a ventricular septal defect, it's emergency surgery. You're not going to have a patient that's 50 years old with all of a sudden a ventricular septal defect. For the test, it's going to be most likely due to an MI. You have necrotic tissue that's developing, ischemic tissue that's going to be incompatible with life, and then you're going to develop a ventricular septal defect. So that's an emergency surgery. No matter the cause, you need to increase the effectiveness of the heart while at the same time reducing the demand on the heart. So to reduce the demand, you're going to optimize the preload. Reduction, you're not going to reduce it very much, remember. You do want to reduce the afterload. You're going to make it easier on the heart to pump. You're going to give oxygen if it's needed. You're going to do mechanical ventilation if it's needed. Mechanical ventilation is actually going to drop your cardiac output, but at the same time, it's going to allow them to rest. It's going to allow them to breathe and be less anxious, and that will eventually overall help the heart out in general. You can do an intra-aortic balloon pump, IABP, and you can do a ventricular assist device. If you're going to need longer times, then you can keep that patient with a balloon pump. Also, you increase the effectiveness by avoiding negative inotropics. You're going to add positive inotropics. You're going to give like norepinephrine, Levophed, dopamine, dobutamine, Primacor. If you ever hear the patients, you get a renal perfusion dose of dopamine or renal perfusion dose of dobutamine. That's what you're helping the heart with, is that effectiveness. So the VAD, the intra-aortic balloon pump as well. The VAD is again used to manage. Just know for the test, it's used to manage left ventricular heart failure. These patients are cardiomyopathy patients. These patients are in cardiogenic shock, and these are used for patients that are awaiting a heart transplant. This is more long-term than the intra-aortic balloon pump. However, you can use the intra-aortic balloon pump for heart failure, cardiomyopathy, cardiogenic shock. Remember for the test that it inflates and deflates, not like the ventricular assist device. So it inflates at the beginning of diastole. This is noted by the dicrotic notch on the arterial waveform, and it's going to help perfuse the coronary arteries. It's going to deflate based on two different settings. You're going to have set on the upward mark on the arterial line pressure wave, or you're going to have the set on to deflate on the upward mark of the R wave on the ECG. So right before systole, the pump is going to deflate, and it's going to help decrease the afterload on the patient. And we're nearing the end. So pulmonary artery catheters, the PACs, are often referred to as Swan-Ganz catheters, and this is just because the two people that invented this catheter, that's their last names, and it's used for diagnostic purposes. The pulmonary artery catheter does a lot of measurements, right atrium, right ventricle, pulmonary artery, the filling pressure, which is the wedge pressure, the left atrium pressures. And also the pulmonary artery. Two useful values for the pulmonary artery catheters are the pulmonary artery systolic pressure, which is between 20 and 30. Some references might have it 15 to 25 or 15 to 28. Just know in general, 20 to 30 is your normal systolic pressure of your pulmonary artery. And your normal pulmonary artery diastolic pressure is between 6 and 12. Some, again, have it from like 8 to 14, 8 to 15, that sort of thing. Just know that obviously it's going to be less than your systolic pressure. So this is where I said earlier in the video that you could measure your left ventricle and diastolic pressure with your pulmonary artery diastolic pressure. These are roughly going to be the same numbers. However, in the setting of cardiac tamponade, left ventricular failure, mitral valve disease, a right bundle branch block, decreased left ventricular compliance, you can have a lot of instances where you cannot use the left ventricular and diastolic pressure as your PAD. So just know that for the test, but just for the test as well, know that your PAD, LV, EDP are roughly the same number, are going to be the same number unless you have these issues right here in the pink box. Just the factors that increase your pulmonary artery systolic pressure are your pulmonary hypertension, your ARDS, your COPD patients, your pulmonary embolism patients, your pulmonal patients. These are the patients that have increased pressure in their pulmonary vascular system. Okay, we're on to acute coronary syndromes. There's some acute coronary syndrome risk factors, pretty general: smoking, alcohol intake, diet, diabetes, hypertension, genetics, age, sex. Unstable angina or angina is unpredictable chest pain at rest. The ECG may show ST depression or T-wave inversion. However, the symptoms that the patient is experiencing can be relieved with nitroglycerin, and that makes the troponins normal. For this test, the non-ST elevation MI, the non-STEMI, is the ECG is going to show the ST depression and or T-wave inversion, same as the unstable angina. Troponins in this case are elevated, so that means they're positive for an MI. And this is unrelieved chest pain, even with nitroglycerin, morphine, that sort. These patients, you're not going to go for a PCI. These patients are going to be on a fibrolytic drip. ST elevation MI, your STEMI. The ECG shows ST elevation in 2 or more contiguous leads. That means leads that are beside each other. Leads 1, 2, AVR. Or leads, say, V1 to V2, or V3, V4, V2, V3, that sort of thing. They have to be side by side. And it's comes along with unrelieved chest pain. So here's a view of some STEMIs, ST elevation MIs. They can look like the fireman's hat or tombstone. Those are the classic signs of a STEMI. These people you're going to be getting to the cath lab or given the thrombolytics. So with ACS, you have variant angina. This is also called Prinzmentals. This is due to coronary artery spasm with or without atherosclerotic lesions. This is going to be transient ST elevation, so just when they're having symptoms, they're going to have ST elevation. This is pain relief that is relieved by nitroglycerin. ST elevation will also return to baseline. So as they get symptoms, they get ST elevation, and then you give them nitro, and then the ST elevation returns to baseline. Their symptoms go away. This may be brought on by alcohol, smoking, cocaine ingestion. These troponins are normal. However, even with ST elevation, these troponins are normal. That's because you're giving them the nitro, you're essentially returning them to baseline. Troponins don't elevate that quickly. Chest pain management. If they get a patient coming in with chest pain, you're going to have a SAT 12-lead ECG. And for the test, I believe they want you to read it and diagnose within 10 minutes. This places the patient in one of 3 categories: STEMI, non-STEMI, or unstable angina. Therefore, you're going to treat the patient based on a severity of risk sort of thing. So for chest pain management, you're going to give aspirin as soon as possible, have the patient chew. You're going to give them an antiplatelet agent, clopidogrel, is one of the common ones. These 2, you're going to hold if they have allergies to both of them, or allergy to aspirin, you're not going to give them the aspirin. Same thing with the antiplatelet agent. You also can give a beta blocker, something that's selective. The common one is metoprolol. The only time you're not going to give this one, the beta blocker, is chest pain due to cocaine use, hypotension, so I would say severe hypotension, severe bradycardia, and the use of phosphodiesterase inhibitors such as Viagra. You don't want the patient to decompensate even more. So pain management, you can use nitroglycerin, morphine as well, oxygen if you're hypoxic. So for the test, you're going to need to know which leads look at which wall of the heart. So there's the left-sided, the normal ECG. There's a right-sided 12-lead ECG that you can do. For the test, I don't believe they do the right-sided ECGs, but just be aware of them. So they're not in this video. Just feel free to study that portion on your own. So this is just with the normal ECGs. So lead 1 in AVL is going to be looking at your high lateral wall of your left ventricle. Leads 2, 3, and AVF are going to be looking at your inferior left ventricle and your right coronary artery, which is your RCA. When you have patients on the monitor, you don't want to have them in lead 2 and 3. You want to be looking at different views of the heart. V1, V2, V3, and V4 look at your left anterior descending artery, LAD, and this is the anterior left ventricle. So obviously, you've heard of an anterior MI. This is where the ST elevation is going to be. This is going to be one of the most dangerous and has the worst outcomes. Your V2, V3 area, V4 is also your septal leads. Those are your right between the ventricles there. V5, V6, 1, and AVL are looking at your left lateral ventricle and your circumflex coronary artery. Like I said, there's more that if you want to look at and study on your own, but we won't cover that in this video. Again, that's the right-sided 12-lead ECG. So some of the treatment for STEMIs is you got to qualify it. So if they've having symptoms that's 12 hours or less, your goal is reperfusion. Again, the criteria is being 12 hours or less, unrelenting chest pain for 30 or more minutes, no response to nitroglycerin, even the third dose, and ST elevation in 2 or more contiguous leads, or a new onset of a left bundle branch block. So to help reperfuse, you're going to have 90 minutes or less. You're going to have the PCI, door to balloon. And in fibrinolytic drug therapy, you're going to have a door to drug administration time of 30 minutes. Post-procedure of the PCI, you're going to be managing your patient and going to be monitoring for chest pain, ST elevation. These are signs of reocclusion, and you need to contact the physician immediately with that. So you're also going to be monitoring for bleeding at both the sheath site after the sheath is removed, and also for retroperitoneal bleeding. So for the sheath site, if you have bleeding there, you're going to hold pressure 2 finger widths above the insertion site for at least 20 minutes. If they've been on Plavix or aspirin, you're going to hold for 30 minutes. So that's going to be most of these patients. Some of the signs for the retroperitoneal bleeding and complications include sudden hypotension, sudden severe low back pain, and for these patients, you're going to give fluids and blood products and notify a physician again. Also, you're going to be monitoring your pulses. Anytime you introduce foreign objects into your cardiovascular system, you have the risk for clots, dissection, that sort of thing, perforation. So you're going to be monitoring the distal pulses from the catheter sites. So the fibrinolytic therapy treatment, contraindications include prior intracranial hemorrhage, a known AV malformation, which often those are congenital, ischemic stroke within the past 3 months, with the exception of an acute ischemic stroke that is 4.5 hours old or less. Active bleeding, significant closed head or facial trauma within the past 3 months. So those are indications for the fibrinolytic therapy for your MI patients, for your STEMI patients. Once they're given this drug, some of the signs of reperfusion are the ST segment returning to baseline, chest pain relief, other symptom relief, and post-procedure, you're going to want to monitor the patient for reperfusion injury. Some of those signs are VTAC, ventricular fibrillation, or accelerated idioventricular rhythm. And that's because you're stunning the myocardium. The myocardium sort of gets used to being ischemic, used to the decreased perfusion. And once all of a sudden you open up these vessels, you're going to get a reperfusion injury. This can also happen with many other organs within the body. Just like your other treatment, you're going to monitor for your signs and symptoms of bleeding or reocclusion. So just some STEMI facts here. Your inferior MI, which is your RCA occlusion, again, you're going to have ST elevation in leads 2, 3, and AVF, with reciprocal changes in the 1 AVL leads, which is your lateral wall. You can also develop a systolic murmur, and this is due to mitral valve insufficiency, in cases with papillary muscle rupture or dysfunction. Again, rupture is a surgical emergency. Also, with your inferior MIs, 30% of those patients can develop a right ventricle infarction. So, in the case of right ventricular infarction, you're going to want to avoid nitrates and diuretics. It reduces your preload. So that means once you get your right-sided ECG, again, there shouldn't be any right-sided ECG strips on the test, so that's why we're not going to go over them. But you have to understand the concept of a right-sided ventricular infarction. You don't want to reduce the preload. That's going to have worse outcomes and decrease the cardiac output even further. So some of these signs and symptoms is JVD at 45 degrees, hypotension with elevated CVP. Not just hypotension, not just elevated CVP, but both. You can have some bradyarrhythmias as well. Again, the right-sided ECG reveals ST elevation and the right-sided V4 lead. Treatments for this is fluids and positive inotropes. So your anterior MI, I've got this starred. This is one of the ones that has a higher mortality rate than the inferior MI, and you need to know this as well. So this is the one with the LAD occlusion, which is your left anterior descending artery. So this will show ST elevation in leads V1 through V4 and have reciprocal changes in leads 1, 2, and AVF, which is to the inferior wall of the left ventricle. These patients may develop a right bundle branch block or a second degree block type 2. Just know that. Again, higher mortality rate than the inferior MIs, and because of these anterior MIs, like I said earlier, the V1 and V4 leads include some of your septal leads and look at some of the septal wall. So if you have an LAD occlusion through the V1 to V4 leads, you can develop a systolic murmur due to, again, ischemia or necrotic tissue developing within that septal wall of the heart. So this will create a ventricle septal defect and creating your systolic murmur. So your non-STEMI treatments. These are patients that are going to hopefully have a better outcome than your STEMI patients. Some of the medications includes the same as the ACS and STEMI medications, your aspirin, your nitrates, your beta blockers, your antiplatelet inhibitors. Your platelet inhibitors. But these patients, if they're unstable, meaning vital sign changes, level of conscious change, you're going to be giving them platelet inhibitors. These patients do not go to the cath lab for an emergent PCI procedure, but you need to prepare them for a diagnostic heart cath within 24 hours. Thank you for watching, everybody. I hope you enjoyed this video. Please visit lifelongnursing.com for more free CCRN review videos and practice questions. If you need help interpreting heart rhythms or anything along that nature, hemodynamics, understanding more about the hemodynamic concepts, please visit lifelongnursing.com. Also, don't forget to hit that subscribe button for the Lifelong Nursing YouTube channel for more content. Be sure to watch the cardiology review question videos for the CCRN. Thanks for watching.